So let's get into talking about instrumental evaluations of swallowing and basically the people that you're going to be performing instrumental evaluations on are just the same people within the general dysphagia population. Lots of stroke patients, lots of dementia patients, lots of cancer, tumor, head injury, neurological degenerative disorders. These are the kinds of individuals you're going to have that you're bringing to radiology for a modified barium swallow, or that you're going to with a endoscope to perform a FEES, or that you are bringing the SLP that does the FEES with the endoscope to the patient. And the two primary forms of instrumental assessment of the swallow that we use are the modified barium swallow, also called video fluoroscopic swallow study, VFSS, or fibroendoscopic evaluation of swallow, which is FEES. Usually what happens is more often than not, you will have seen the patient and will have done a bedside evaluation, detected that there may be a problem or that there is a problem, and you have referred that patient for a modified or a FEES to confirm that there is a problem and to tease out exactly what that problem is. Because as we've mentioned, no matter how good you are at a bedside evaluation, you can never be 100% sure that an individual is not silently aspirating. You can be pretty sure, but you can't be 100% sure. So more often than not, anytime you do a bedside evaluation, if you think there is the possibility that this person has an issue swallowing, you generate that referral for an instrumental assessment. Or if you're the person receiving the referral for the FEES or the modified. So if another SLP is referring that patient to you at your facility, then you're going to get the referral. You're going to call the SLP. You're going to tell them to send you their bedside evaluation so that you know best how to prepare and what to target when you get into that evaluation. You don't want to go in blind. So some risk factors that indicate potential dysphagia. So let's say you do a bedside eval and the patient looks fine at the bedside eval. Normally you wouldn't refer them for an instrumental assessment. But if you look into their file and if they are having recurrent pneumonia, and especially right lower lobe pneumonia, then that is a red flag to you that pneumonia could be aspiration pneumonia. So anytime as an SLP we see right lower lobe pneumonia, basically we go on to high alert. And if you recall, that is because your trachea, as it comes down here, the primary bronchi going off to the left lung is at a sharper angle than that primary bronchi cutting off to the right lung. So whatever you aspirate is much more likely just to travel down into the right lung than it is to suddenly take a hard left, just due to inertia. So right lower lobe pneumonia indicates a problem to us. And maybe it's not aspiration pneumonia, but you have to go rule that out. If they have a history of radiation to the head or neck, then what you know now is there's a good chance there's some degree of fibrosis. And if there's some degree of fibrosis, that probably means some loss of muscle function. and that could easily translate into a dysphagia. So even if they look fine at bedside, you would generate that referral for an instrumental to be certain. And let's say you have someone come to you, it gets referred to you, or someone comes into your hospital or nursing home. You see them at bedside, they look great, but then you look in their file and it was like severe dysphagia, like a year or two ago. You can't really trust your bedside eval with that in there either. Because once again, there's a good chance that if there's a much better chance of there being silent, there's a much better chance of aspiration and penetration being present in someone with a history of dysphagia, and therefore a much better chance of the presence of silent aspiration. So you would look at them at bedside, but then you would still refer them to the instrumental assessment. Anytime the patient complains that there's a food getting stuck, if there's food getting stuck or they're getting choked up, you could look at them at bedside and they may look fine. But that doesn't address the issue, that the patient is still saying like, yeah, well, I looked fine when you gave me that stuff, but I'm still feeling like something's getting stuck here. I can still feel a problem. You haven't answered the question as the SLP. So you generate a referral for an instrumental assessment. And obviously, anytime there's prolonged intubation, as we've discussed, muscles can atrophy, which can create all kinds of difficulties with appropriate mastication and deglutition. And if you have someone that is decreased alert and decreased mental status, then you might not be able to get anything at bedside. If this is a patient that has periods of decreased alertness and mental status, then you want to wait and be sure you get a good bedside evaluation of them when they are not in that condition. Because I know when we went through the last section, I said that you don't want to take someone that is decreased mental status down to radiology, because there's a good chance that's not going to go well. But that is, to elaborate on that, you don't want to take them down to radiology if they have decreased mental status or decreased alertness, if you have any other option. So if there's a period when they are more alert, then you will go and you'll see them at bedside first. But if you get someone in, if you can't get anything at bedside, like maybe you're able to get them to take a teaspoon of this or that, but you can't tell what's going on. And if they have no period of higher level of alertness, then you just got to discern what you're able to discern in radiology. And probably what that's going to look like is getting the person confirming that this person does need a feeding tube placed. So to review, during your bedside eval, the things that you're looking for that indicate to you potential problems: coughing, throat clearing, wet vocal quality, after presentation of the liquid or the bolus. But here's the thing. Let's say you have someone that has pneumonia. They're already coughing. Let's say or someone with any respiratory illness, they're already coughing. They're already wet and mucousy when you go in there. They're clearing their throat. They got mucus rattling on their lungs. They've got mucus rattling on their vocal folds. You're not going to be able to discern much. When this happens, you say, well, I don't know, let's see what happens, and you very carefully go through your bedside evaluation. But if I walk into someone's room and I see they're already coughing and throat clearing and coughing stuff up, I already understand I'm probably not going to be able to discern much at the bedside. But this guy has been referred to me for swallowing, and he's already displaying the potential for the presence of pneumonia. So I'll probably confirm that I can't get anything at bedside. Then I'll generate the referral for the instrumental because I'm not able to see anything at bedside. I'm not able to discern anything at bedside because of the sickness that is already there with the patient. But during modified barium swallow, I'll be able to see everything clearly. Also at the bedside, you look for reduced hyolaryngeal excursion. You look for stasis in the oral cavity, which is going to indicate to you a lack of bolus manipulation, lack of possible bolus control, possibly difficulty. You look for a slowed swallow reflex, which is going to communicate to you that the person is having a delayed or absent swallow reflex. You're going to note, like I said in the video where I modeled the bedside for you, when you put the bolus in their mouth, does it take them multiple swallows, which is piecemeal deglutition? You want to note any delayed coughing or throat clearing after the bedside eval. It doesn't always happen immediately. Very often, you might be packing up your books and suddenly that person goes into a cough. So you might go through your entire bedside evaluation. You think, oh, no problem. You're packing up, and all of a sudden your patient bends over and starts hacking. They weren't doing that when you came in. They're doing it now. You can't rule out that there wasn't some stasis in their pharynx that fell into their airway and that is causing them to cough. So in that scenario, you would refer them for an instrumental assessment. So if you see any indication at bedside that the person may be having a swallowing issue or may be at any heightened risk for having a swallowing issue at bedside, then you refer them for an instrumental.